Hello dear colleagues, patients and anyone who's interested in the aspect of airway in dentistry and its impact on the patient's physiology, on all the other systems, and how we can improve it through our input into patient's treatment. We're going to go through the pathophysiology, anatomy, and the symptoms we can detect in the patient's mouth, but also outside of it, literally since the patient walks through the door, to the medical history and all the symptoms they tell us about. I hope through this course a completely new world will open to you, and a lot of new questions will raise in your head when you will spot certain symptoms or hear certain symptoms the patients will mention to you about the quality of their sleep and any pains or TMDs, Bruxism and Sleep Apnea, because for a very, very long time we didn't really know the origin of these symptoms. We knew a whole lot about the changes in the anatomy, the symptomatology, but we didn't truly know where does it all start. And I was just very lucky to work in the right place at the right time, to meet Dr. Stephen Olmos from San Diego, America. He came to England and basically made it very clear for the first time and very understandable. And since then I couldn't stop digging more. I've read all the available literature, everything he indicated, and I had an amazing opportunity to watch how the specialists treat the patients with temporomandibular joint dysfunctions, sleep apnea, chronic pains, very difficult patients who are basically not understood by many clinicians because the symptoms seem really uncorrelated. And a lot of these patients are kind of directed to psychiatric units, and they really felt that they are not understood and there isn't really hope to help them. The treatment I had a chance to see was based on removable appliances. After a year I had a chance to treat patients to restore them implantoprosthetically in a fixed manner, and their symptoms were very obvious to the ones I had a chance to learn about. And I thought maybe I can perform it in a fixed manner, because these devices, these patients have to wear to the rest of their lives. And to my absolute amazement, especially the young patient, their life has really turned around. The changes in the bodily functions, starting from a lack of pain, better sleep, its impact on digestion, and also being able to chew and take in more varied food, and also sleep and regenerate has had a fantastic impact on other organs. So we filmed the patients after 3, 6 and 9 months, and the difference was so immense that I've decided to share that with everybody. During that journey, it was collaborative work. I did consult all the steps, and I also had amazing clinicians to answer some questions along the way, and also technicians, so I'm very grateful, and hopefully by sharing it somewhere really far, you are able to help your patients as well. Hopefully you will feel confident after this course that you can do that without really dreading a damage, because it is used with materials that patients can alter themselves with their function. You will see it all and you will assess if you would like to use it or not. It's absolutely up to your clinical judgment. I also would like to ask you if you'll see any content, anything that you consider that belongs to anybody else, anybody's copyrights, please contact me. Write to Devon courses@gmail.com, or contact me through our website or Facebook, and any of this content or images will be removed or addressed immediately. I hope you will find it useful, and we will all keep in touch and develop further. Thank you. At least once in your career, you probably came across such a site, and you probably wondered why it has happened. There are many courses out there that are really good ones. They are very helpful to know how to rebuild the dentition, but still it was a mystery. What is the origin of such a damage? I must admit, I feel I was at the right place at the right time, and I have met Dr. Stephen Olmos, who came with lectures to England, and for the first time it really seemed very logical, very clear, easy to understand. It wasn't such a mystery with a lot of ifs and buts. And also learning that his patients are free of pain and the results are stable, I felt it's something very important. The further I digged into the articles and the knowledge he suggested to gain, I realized that also patients' general health was immensely improving. Their blood pressure was regulating, they were free out of migraines, they were basically coming back to life. So I took every chance to observe how the specialists are working and help these patients. And usually the treatment involved a removable appliance which patients did have to wear to the rest of their lives. And I did wonder, what if we rehabilitate them in a fixed manner, knowing that these symptoms are there and most likely their airway are impacted through a narrowing, causing this damage. And a year later, I had the opportunity to treat such patients. I was obviously a little bit nervous, but I have consulted all the steps. I was also very lucky to have a very smart colleagues who I went for answers as well, very helpful technicians. And after the treatments was finished and it was stable, and we have reviewed it after 3, 6, and 9 months, and also during the treatment, I really felt this is something important that I would like to reach more clinicians who would like to help such patients. So hopefully you will find that of use as well. So here we have a row of abfractions, which indicates that there is a general clenching happening. If we would be an isolated one or two next to each other, it could be an orthodontic malposition of the opposing tooth. But if you can see that in a multitude of teeth, it indicates that there is a general clenching happening. So the way they occur, if you would imagine sitting on a round big ball, at the very curvature of it, the elements would fracture out. They would be pushed out. And this is what happens here. Sometimes we hear explanation like maybe aggressive brushing, but because the enamel is the hardest tissue in your body, brushing should not really remove any of its structure. Here we have another example of multiple abfractions in neighboring teeth. Also, you may notice a vertical crack and horizontal where we lost the anatomy in the incisive area, which indicates a lot of movement happening here. Horizontal grinding, but also clenching, which will develop the crack lines and abfractions. Here we have an even wear of the incisive edges of upper and lower arch, which would indicate a lot of horizontal movement, meaning grinding. Because we have less abfraction, it looks like it's quite a dynamic movement. We may ask as well if the patients possibly have a restless leg syndrome. Is he quite not at ease? Is it hard for him to fall asleep? And when he wakes up at night, is it easy to go back to sleep? Here is another feature, which is quite a classic site where we deal with grinding, clenching, or patients with OSA, obstructive sleep apnea, where they're fighting to brace the jaw, keeping the airway open, and the teeth are getting the hit, hence the wear. And if the problem is not addressed where it originates, all the patch-up composites, they will keep breaking because the patient is still fighting to breathe. Here is a feature which I think is the dentist's worst nightmare, where we have a very extensive work, a long bridge, which is an expensive work, and in this case where we lose porcelain, which is fractured, chipped away, means the whole work needs to be redone. But it does also indicate the need for understanding why that has happened and what to do so it does not happen ever again. It indicates a bit more problems that the patient is suffering with. It is not just a matter of applying a material that will be more resilient and will bear the forces, but ideally to address the reason why they occur in the first place. Now, the feature we see here very often coincides with worn teeth, chipped porcelain. It is those masseter muscles that have to do this bracing work, and they do overgrow with time, and we end up with more square face shape. And it's quite a common feature for bruxing and clenching patients. Another feature that may raise our concern is when we see quite young patients who do have periodontal problems, but the movement of the teeth is very rapid, and you would expect that in more elderly patient. The answer here is the tongue thrust. If you think of the root of the tongue that is near to the wall of the throat when patients are laying flat, and we want to push it to the front to open the airway, and it happens multitude of times at night, this is the result, the migration of the teeth in the frontal aspect on this image. Now on this image we can see a lateral open bite, which indicates a tongue thrust kind of pushing sideways. Sometimes that happens when we have a large tongue, and it happens to the young patient where the molar teeth are erupting a little later. We can also see the lower incisors also leaning to the front, and this is where the tongue is pushing. The forces of the tongue, they can cause an orthodontic movement. It's a pressure like any other pressure, like you would have it from orthodontic wires or removable clear aligners. Here we have a classic feature of attempt of trying to position back the teeth that have been kind of thrusted out, but without addressing the origin of such movement, which is basically inability for the patient to breathe through their nose, for the room for the tongue, where the upper arch needs to be widened and the lower arch then has a room also to expand. When the teeth are just removed and everything is moved towards the inside of the mouth, it just will be unsuccessful. There will be relapses, and even if we brace the teeth with a fixed cemented wire, the whole aspect will move eventually. At least once in your career, you probably came across a similar image of torus palatinus or torus mandibularis. And as it was a mystery for me for most of my career, during writing this thesis, it became apparent that it is in the areas where muscles are attached. And these muscles, if they have to make an extra work, they will cause the bone to thicken, to be more resilient, and take on more on the load that is put upon it. Obviously, not all the patients are prone to such an extensive overgrowth, but if you do see them, you can also recognize more symptoms telling you that these patients probably fight for their breath, especially at night. You can then ask, what's the quality of their sleep? Do they grind their teeth? You will have a lot of questions arising in your head after this course, and hopefully it'll guide you to the right direction. Throughout this course, you will also learn what does it mean, the forward head posture. It basically increases the volume of the airway, which allows the child or adult, whoever experiences narrowing in that area, to breathe more effectively. Children who mouth breathe, it's a very common kind of position of the head, and even if you tell them to straighten their back and use really interesting devices to remind them of it, it will just not happen unless the volume of the airway is brought back, and automatically the head posture does come back to its design position, which I have found quite remarkable when I learned that from Dr. Olmos. And here he is, Dr. Stephen Olmos himself. We can see that he's a past president of the American Academy of Craniofacial Pain. He deals with the TMDs and sleep disorder breathing. He has many diplomas, as you can see, dealing with craniofacial pain, dental sleep medicine, also an integrated pain management. So you can see that he has really dedicated his life to this subject. He also helped to establish about 70 centers across the world that help patients with these issues. He has developed a triaging protocol and treatment protocol, and from all these centers the data are collected to check if the results are stable and how the protocols can be improved. Because Dr. Olmos' triaging process addresses the whole of the patient, very often the origin of the problem is found outside of the dental area. Hence, he is working relentlessly with general doctors, with neurologists, pediatricians, physiotherapists, to help to find where is the real trigger of patients' problems. These patients very often are categorized as psychiatric patients who cannot really be understood where the pain originates from, and very often they're really left to themselves, only support groups, and he does give them hope. And I am very proud to take this knowledge a bit further, and hopefully one day it'll be in all medical schools, general and dental, and Dr. Olmos can establish the recognition for his achievements, for the input in the whole of the medical field. During this course, I will demonstrate the dental part of treatment and show you the difference if we address the symptoms within a young patient and one that has suffered for over 25 years, and just to show how valuable it is to help somebody as soon as possible when we discover where that can lead to in the long run.